Once again, good evening, everyone. Today we are going to see child psychopathology. It's a very interesting topic, especially for counselors. So we will learn about the major disorders of child psychopathology. First, what is child psychopathology? So, what are disruptive behavior disorders? When we look at psychopathology, the definition of psychopathology is very simple. It has mainly to do with the manifestation of psychological disorders in children and adolescents. They're very simple even from an examination perspective or from a counseling perspective. Rendliyo onneda.
Alan, can you hear me? Hello?
Yes.
Alan?
Good evening.
Good evening. You started recording?
Yes, I have started recording.
Okay. Yeah. I'll cover the login. Because I want to remind you. Yeah.
No problem. Thank you.
Yeah, thanks.
Okay. So when we are looking at the definition is whether in a counseling context or in from the context of our examination is the same. It is a manifestation of psychological disorders in childhood and adolescence. நாங்கள் developmental psychology படிக்கும்போது developmental stagesல both childhood and adolescence. அந்த ரெண்டு ஸ்டேஜும் பார்த்தாலும் children are very vulnerable to psychopathologies. So நாங்கள் மெட்டீரியலை பார்த்தா it lists three major psychopathologies, which is oppositional defiant disorder, ADHD, and conduct disorder. இந்த மூணு நாங்க பார்ப்போம். இந்த டீடைல்ஸ் இப்போ நாங்க பார்க்கும்போது we will see it in three ways. We will see first the etiology, that is the causes, whether it is biological, either psychological, social, temperamental. நீங்க கவுன்சிலரா நீங்க பிராக்டிஸ் பண்ணும்போது you will come across even the genetic component. ஆனா one aspect நாங்க clarify பண்ணிக்கலாம். Genes or genetic predispositions do not directly contribute to behavior, but genes produce certain proteins. These proteins, along with many other factors, contribute to the development of certain behaviors, like whether those are internalized, like depression or anxiety, or externalized, like aggression. So material they have not emphasized the genetic component very much. They have emphasized the biological, physiological, social, and temperament. Second item we will see is the course, the consequences, and importance of understanding comorbidity. Comorbidity, the existence of multiple pathologies within a single patient. So for example, நீங்க depression பார்த்தா depression can manifest differently. It may present differently in an adult. It will present differently in a say a 7-year-old child. For example, it may present differently in an adolescent or a teenager. So for example, depression in a 7-year-old may present as irritability or somatic complaints. Many times depressed children will say will complain stomach ache, talavali irukku, vairu vali irukku, or one leg or one hand or generalized fatigue, they will complain of somatic. Those are somatic, to do with the with soma, that is the body complaints. Adolescents, we see this behavior more aligned with adults. That is, they will have low mood, they will have a poor affect, they will have feelings of hopelessness. So இங்க நாங்க authoritative guidelines as master's students, நாங்க எப்பொழுதும் we have to look at the authoritative guidelines. For example, DSM-5, similarly the American Psychological Society, அவங்க publish பண்ற guidelines, we must look at those guidelines before we consider what a condition is. So we will also look at some cases which have been published. Now, coming to the next slide. Today, what we will define child psychopathology, which we have done, and we are going to explain why early problems are important. Now, நான் இதை எப்படி ஸ்ட்ரக்சர் பண்ணியிருக்கேன்னா, I have followed the general flow of our study material with a few extra points added based on DSM-5 and other child counseling and child psychopathology material which can be verified. I will share the details with you. Second, we will describe the etiological factors, that is the causes and risk processes. நான் சொன்ன மாதிரி genetic, temperamental, parenting influence, environmental influence, these are very key to understanding psychopathologies. Third, we will identify and differentiate core clinical features of these three conditions, the three most prevalent conditions: ODD, CD and ADHD. அப்புறமா நாங்க பேரண்ட் சைல்டு இன்டராக்ஷன்ஸ் அண்ட் ஃபேமிலி கான்டெக்ட், சிப்ளிங் கான்டெக்ட்டையும் பார்ப்போம் நாங்க, ஹவு இட் ஷேப்ஸ் பிஹேவியரல் ப்ராப்ளம்ஸ். Then we will apply concepts to real world case studies. These are famous case studies for each of these psychopathologies. Now, one caveat idla irukkiradhu is it is important to note that psychopathologies are not simple. Many times, some cases will be clear cut. நீங்க கவுன்சிலிங் செட்டிங்ல இருக்கும்போது பேரண்ட்ஸோட பேசி கேஸ் ஹிஸ்டரி, இல்லைன்னா டீச்சர்ஸோட பேசி கேஸ் ஹிஸ்டரி நீங்க எழுதும்போது சில பாயிண்ட்ஸ் you will see the red flags immediately. It will become apparent very soon. ஆனா சில கேசஸ்ல இஸ் வெரி காம்ப்ளெக்ஸ். நான் ஒரு கேஸ் பார்த்துருக்கேன் வேர் பேஷண்ட்டுடைய காக்னிட்டிவ் எபிலிட்டிஸ் ரொம்ப ஹையா இருக்கிறதுனால, இட்ஸ் அ வெல் எஜுகேட்டட் பேஷண்ட், அவங்க காக்னிட்டிவ் எபிலிட்டிஸ் அண்ட் காக்னிட்டிவ் ஃபங்க்ஷன் ரொம்ப ஹையா இருக்கிறதுனால இட் மாஸ்க்ஸ் மெனி ஆஃப் த டிப்ரெசிவ் சிம்டம்ஸ், ஆங்ஸைட்டி சிம்டம்ஸ் எட்ஸெட்ரா. ஹை ஃபங்க்ஷனிங் டிப்ரெசிவ்ஸ்லையும் ADHD, ODD, these are very difficult to discern even by a psychiatrist. So we must always keep in mind that inga explain panna principles are very broad. Specific case we will have to apply specific diagnosis and specific treatment patterns. Lastly, we will outline the main principles of assessment and treatment and prevention of disruptive behavior disorders. DBD is the abbreviation. Now, so we defined child psychopathology is the manifestation of psychological disorders in childhood and adolescence. This is a very serious problem. It is a very prevalent problem. Many times நாங்க எல்லாரும் பார்த்துருப்போம் what some of the symptoms, what we think of symptoms. In fact, if we all get the opportunity to share, I am sure that many of us will have one case or the other where we recognize these symptoms. So these psychopathologies include externalizing or disruptive uh, disruptive disorders such as ODD, CD, and ADHD, or internalizing disorders like anxiety and depression. Developmental disorders like autism spectrum and intellectual disabilities, and other comorbid disorders, contributing disorders like sleep deprivation, eating disorders, learning disorders. In many children, நீங்க கிளினிக்கல் செட்டிங்ல பார்க்கும்போது இது ஐசோலேட்டடா வராது. It will come together. So that is important to understand. Now, நம்ம மெட்டீரியல்லையும் this is a heading, significance of childhood disorders. Historically, adult disorders have received more attention and resources. Now, we understand adult disorders. So DSM-5 and ICD-11 are the main criteria, are the main standards for understanding. In fact, நீங்க மெட்டீரியல்ல பாத்தீங்கன்னா பெஞ்சமின் ரஷ்னு ஒருத்தர் இருக்காரு. He was the American psychiatrist. அவங்க என்ன சொன்னாங்கன்னா, children are less likely to suffer from mental illness because their developmental brains prevent them from remembering or retaining the mental the events which causes insanity. So children cannot suffer from insanity ni அவங்க ஒரு ஸ்டேட்மெண்ட் அப்படியே அவங்க ஒரு ஸ்டேட்மெண்ட் பப்ளிஷ் பண்ணாங்க. பட் வி ஆல் நோ இது 1812ல, பட் வி ஆல் நோ டுடே தட் சில்ட்ரன் ஆல்சோ சஃபர் சைக்கோபேத்தாலஜிஸ். நம்ம டெக்ஸ்ட் புக்ல தேர் இஸ் அ குட் ரீசோர்ஸ் கால்ட் மேஷ் அண்ட் பார்க்லி. அவங்க ஒரு மேஷ் அண்ட் பார்க்லி இஸ் அ ஸ்டாண்டர்ட் டெக்ஸ்ட் புக். நீங்க கூகுள் பண்ணா மேஷ் அண்ட் பார்க்லி நீங்க கூகுள் பண்ணா third edition is available online as a PDF. It's a very very good book to understand psychopathology in children. So இப்போ நாங்க பார்க்க போறது, we are going to see many psychological problems. They begin in childhood, they will persist into adulthood. Yeah, among people you know, some of us may have suffered some of these psychological problems, and நாங்க trace பண்ணலாம். For example, depressive episodes in children may lead to depressive episodes in adults or even adolescents. So which is why taking the case history well and detailed. For example, in a hospital once, I have observed, and I mentioned it in my last class, case history, the patient case history took 45 minutes, 40 to 45 minutes. Then relatives case history took another 45 minutes to an hour. That is the minimum amount of time we will have to spend. So early now, that is the importance of taking a good case history. Now, early behavioral can have long-term consequences: academic failure, poor school dropout, poor relationships, social isolation, and a risk for substance abuse, drinking, drug abuse, criminal behavior. So the purpose of studying psychopathology, நீங்க டெக்ஸ்ட் புக்ல பாத்தீங்கன்னா ஒரு 2000 word paragraph எழுதியிருக்காங்க. ஸோ அதை நான் கொஞ்சம் ஸ்பிளிட் பண்ணி I have taken the main themes that we can take away and study it in a brief manner. So child psychopathology allows early detection. The earlier we detect, the faster we can intervene, and the intervention it will be less invasive. Then the second benefit is they can develop preventive strategies. Just because somebody had a psychological problem in childhood does not mean they have to carry it into adulthood. The third is we can reduce with a good therapeutic environment and intervention, we can reduce the personal and social costs and the time lost in in overcoming these psychological problems. Now, how common are these? Prevalence. நீங்க டெக்ஸ்ட் புக்கோட ஃபாலோ பண்ணிட்டு இருந்தீங்கன்னா இட்ஸ் இஸ் ஆன் பேஜ் 139 ஆஃப் counseling for children textbook. Now prevalence, I have taken the first half from the textbook. About 14 to 22% have a significant mental health problems. On the London study, Ontario study, some numbers they have reported. And Indian studies, more recent Indian studies, following the childhood psychopathological measurement schedule. Idu ninga Google panikkalam. It is based on ICD-10 criteria, but ICD-11 also will confirm. We can see that these childhood psychopathology is quite prevalent and at an alarming number of one particular paper showed 28%. That is out of 3 people, almost out of every 3 people, 1 person has some form of psychopathology, whether minor or major. Now, the study which I saw observed that mid-adolescence, 13 to I'd say 13 to 15, lower socioeconomic strata, people with working mothers, single parents, many of these children suffered from psychopathology. Psychiatric problems were found to be about 20.8%. Severe, again, is about 10%, 7 to 10%. So, in India, childhood psychopathology is a growing concern, which makes it very important for us as not only as counselors, but as parents, as potential parents, as uncles, aunts, friends. It is very important for us to be able to recognize these psychopathologies, or at least if we may see the beginning of these things. Okay. Now, despite the prevalence, 28% in India, அது இருந்தாலும் only 20% of affected children receive adequate mental health care. அதுவும் from higher socio-economic backgrounds. Poor children do not receive any counseling or psychological care. And many of these children later on are in juvenile justice system. They develop adult psychiatric disorders like psychosis, schizophrenia. They cannot, because of the stigma attached with psychiatric disorders, they struggle. They cannot have they are not able to work, they are not able to have relationships, their physical health also suffers. Now, the reasons, காரணம் is first denial. Because of the stigma இருக்கிறதுனால, we say, okay, childrenல it is just a phase, it is just behavior, some bad behavior. அது ரெண்டு அடி கொடுத்தா he will be fine, she will be fine. No, that is not the correct approach. Symptoms are misinterpreted. So the third is, many cases mental health services are not available to children. Recently, a personal account I can give you. Recently, in my daughter's school, a young boy committed suicide, and it was in the newspapers. It was reported on all the news channels. Very difficult situation, and many of the students had no idea that there is access to mental health, even in an urban school. So it is a very serious problem. Okay. So some of the challenges in defining child disorders is high overlap between symptoms and diagnosis. Many suffer from comorbidities. The second issue is, what is a normal developmental problem? What is a clinically significant disorder? How do we determine what is normal and what is clinically significant? So here it is, there are 2 points we must keep in mind. One, is this behavior in the normal range for the child's developmental stage? So as a psychologist, as a counselor, in any time நாங்க கேட்டுக்கணும், is this, we must be familiar with the behaviors, cognitive abilities of a child in the developmental stage, and ask, is this normal behavior, or is it excessive, persistent and impairing? Excessive na அதிகமா இருக்கு, persistent continuous-ஆ இருக்கு, impairing, does it interfere with their daily life? These are important. We must look at very carefully whether these 3 criteria, excessive, persistent and impairing, compared to other children, peers of the same age. So children with the same diagnosis may have different etiologies or different cause, different manifestation. One child may may internalize, another child may externalize. So it is important to note the difference. Moving on. Now it's important to understand multifactorial etiologies. Multifactorial etiologies could be genetic variables, brain structure, biological factors, inborn emotional and behavioral responses, that is under temperament, emotionality, how emotional is the child. In Indian context, நீங்க கேட்டுப்பீங்க, ஓ அவங்க ரொம்ப இமோஷனல் ஆயிடுவாங்க. நாங்க ப்ரொஜெக்ட் பண்றது லைக் இட் இஸ் அ வீக்னஸ். Emotionality is a measurable attribute. Ana, at no point in any setting should we project it as a weakness or as a strength. The person's activity control, whether they have effortful control, they have self-regulating mechanisms, behavioral mechanisms, temperamentally how are they, adu naanga paathukom. Psychological factors are things like cognitive styles, self-concept. ஒரு குழந்தை, what do they think of themselves? அவங்க ஒரு டிஃபிகல்ட் சிச்சுவேஷன்ல இருந்தா how do they cope? I got a good example from a school student. இப்போ போர்டு எக்ஸாம்ஸ் வருது, நான் ஹாலில் இருக்கும்போது எல்லாரும் exhibiting various behaviors. Some people were crying, some people were shaking their head, some people were hyperventilating, breathing very fast. And this child said, I looked away from all those things, focused on my paper, and I wrote my paper. That is a coping strategy. To focus the mind on the task at hand. It is a coping strategy. The next psychological factor we have to look at is emotional regulation skills. Is a child able to regulate their emotions? Social and environmental factors which we must see are parenting, their attachment styles. Are they avoidant? Are they confrontational? Peer relationships, whether they have friends in school, whether they have a good friend circle, what is the school environment, or stressful or traumatic life events. For example, death of a parent or death of a grandparent, death of a classmate. These etiologies, these causes can trigger different psychological reactions in our children. So now let us look at, so before we proceed, are there any questions at this stage? Any questions or anything you want to share at this stage? Okay. If there are no questions, let us proceed. Give me 1 minute. Okay. Now, moving on to the role of parent-child relationships. Now, we have found that emotional stress in the parent-child relationship is a central factor in childhood behaviors. Parents and children spend the most amount of time with each other. Sometimes teachers or classmates spend time with them. Only teachers and classmates in school may spend equal, comparable amounts of time. So, early separation, anxiety are the foundation of later emotional difficulties. So, for example, textbook material கொடுத்த example is Raposa. They have indicated that more childhood psychiatric diagnosis at age 15 and higher mother-child relationship stress at age 15 can result in higher maternal depression at age 20. There are other studies which confirm and connect that a relationship between the parents and the child is a long lasting has long lasting implications uh, for both psychopathologies and various other psychiatric issues. So, for example, relationship between a child's problems and parental distress is bidirectional. What does this mean? If a child has behavioral or psychological problems and the parent has it, both can influence one another. A parent some with a psychological issue can influence a child. A child with a psychological issue can influence a parent. Both are possible, both occur. So, before we go into that, it is important uh, to understand emotional stress or trauma in the parent-child relationship. For example, can somebody give me an example of something that causes emotional stress or trauma in the parent-child relationship? One example, please. You can unmute your mic or you can put it in the chat box. Anyone?
The the emotional abuse.
Excellent point. Emotional abuse of the child by the parent. Anyone else? Anything? Any other example related to emotional abuse?
Of late, also sexual abuse.
Excellent
Lot of
point.
we come to hear about that. Parents, even the parents, particularly the father and the
Yes.
girl child.
Yes. Childhood sexual abuse, CSA, and emotional abuse, physical abuse, punishment. These are all triggers for many psychopathologies. Both internalizing and externalizing disorders can be triggered uh, these and other um, parental child-parent relationship issues. So here another important point: paternal stress and depression. Today we live in a society where both parents are under high emotional pressure. both at the workplace and in terms of work-life balance. Now, Indian culture, you can see this very clearly. We are a very hardworking culture, but we are also an excessively hardworking culture, where it is natural, it is expected in the workplace to sacrifice your family life to work. It is not surprising that we have a 28% child psychopathology rate, which is only going to increase if we do not urgently sort this problem. So parental stress and depression can worsen child behavior and emotional problems. Now, family context. Some of the findings quickly are: older siblings' depression or antisocial behavior will increase the risk for younger siblings. So maternal depression, sometimes even, for example, in a family case where the family has an older child who is about 3 years old. The mother has had the second child. She is suffering from postpartum depression. Postpartum depression can affect even the older child. Later on, antisocial behavior from an older brother has been shown to be harmful for younger sisters. Externalizing behaviors like aggression have been shown to have have been connected to harmful internalizing behaviors like anxiety in younger sisters. The possible mechanisms is: one, it is the modeling of maladaptive behavior. Many parents are not educated in the correct form of behavior, and this comes to children learning by watching the parents. How the interparental relationship, how is the relationship between the parents, how is the relationship in a house where there is a sibling, how is the relationship between each parent individually and that sibling compared to the relationship with me, the younger child. Family conflict, arguments, fights, physical abuse, these are some of the possible mechanisms for psychopathology. We are not talking about normal developmental issues like a child having a tantrum. Please do not look, if you see a child having a tantrum, they do not have a psychopathology. That is a very, very far stretch. Psychopathology can only has to be diagnosed very carefully. Then, less emotional and practical support for the younger child. Those of us who are younger children or third children will know, because parents are busy. They have already they are taking care of the interests of the older child. Sometimes the younger child will be neglected. Girls are more sensitive to pathological family environments. Girls are sensitive to high stress, parent-child or interparental stress, and they often show internalizing symptoms like anxiety and depression. These are confirmed by longitudinal studies. They are confirmed by multiple longitudinal studies. So, நாங்க 10 marksல எழுதும்போது, from an exam perspective, it is important to be able to identify these points in the family context. Next, temperament. Temperament, these are based on the Big Five scale. So children who are high on emotionality and high on neuroticism, they show strong emotional negative reactions. They are not able to control their emotional response to a situation. These are vulnerable. These children are vulnerable. Those who have short attention spans, those of us who work with special children, you have my great respect, because you may be seeing this every day. Some of you who work as counselors for children or as teachers, you may be seeing this more and more every day. You will have time at the end of this session to share your experiences, definitely. But this is something you may have seen, an effortful, low effortful control among children. As a result, the probability of conflict becomes high. The probability of conflict with parents, with peers, and it makes it difficult for children to learn adaptive coping or emotional regulation. And when they come into a high stress environment, they are not able to understand how to regulate their emotions or their thoughts. And so they are at risk for later disorders. Now, disorders can happen at any age. So it is important in children, whether they are in childhood or early adolescence, middle adolescence, or late adolescence. These, in a clinical setting, we must remember that these can happen at any age. So there are three important pillars. One, there are risk increasing. What causes child psychopathology? Etiology, domestic violence, parental divorce with conflict, physical, like many of you pointed out, physical, sexual, or emotional abuse, neglect. Children are left alone for many hours, loss of caregivers, loss of parents, forced relocation, change of school, change of city, and chronic poverty. Mental health, particularly in southern states in India or Northeast, chronic poverty is a very, very high contributing factor. This leads to an increased sensitivity. They will danger illanalo, they perceive it as danger. For one example I want to cite is which they bring up many times is the child in the womb being affected by the mother's stress level. There is a physiological reason. In the womb, the womb environment is rich in cortisol receptors. The stress hormone cortisol receptors they're very rich in it. So the stress of the mother passes through the cortisol will even influence a child's well-being. The exact mechanism is still being studied. But this is one example that it is so important for us to understand. Second, the risk increasing experiences, they reduce sensitivity to reward. So for these children, positive experiences are not motivating. You will see this many times. Teachers who work with low income groups, sometimes children will not enjoy the reward, or they will be cynical towards the reward. This is one of the signs that we must look out for. Difficulty in recognizing emotions. Children who have a tendency or a predilection towards psychopathy, they have difficulty in reading facial expressions. They have no empathy. Now, this can lead to conduct disorders, anxiety, depression, aggression, like we said earlier, both internalizing and externalizing disorders. In our textbook, and this is a good finding. It is from 2001. It has been updated, but it shows a 4-factor model. The 4-factor model that propounded by Vasey and Dads, that talks about genetic influences, the biological, that is genetic influences, brain development, hormonal development, neurotransmitter systems. We learned about these in our first semester. Each neurotransmitter has a distinct influence on certain conditions, certain disorders. Psychological processes, that is their cognitive appraisals. A child who has a psychopathy may interpret ambiguous, harmless to a normal person, but even but they will see it as hostile. For example, in a school, in a class environment, the teacher may say something to encourage the child, but the child will see it as an attack. Self-esteem and self-concept, these are, we understand these coping strategies we discussed. Parenting styles, whether they are authoritative, authoritarian, permissive, or neglectful, these again we studied. These are the one of the factors that affect psychopathy in children. The quality of attachment styles, family communications, peer relationships, baseline emotional reactivity, which is a measurable attribute, and the ability to regulate those emotions. So these are many factors that as counselors, as therapists, or even as students looking at a child or at a patient, it is important to know that these are all connected and influenced. Those of us who have interest in neuropsychology, you will find there is a lot of research that they have done in the recent times through EEG studies and various other studies that show the cumulative influence, not a single cause, but a cumulative influence of all these biological, psychological, social, and temperamental factors. How does psychopathy manifest in children? It may show as anxiety related, that is as separation anxiety, generalized anxiety. They may have phobias, phobias of insects, phobias of various things. They may have attention problems, that is they are not inattention, hyperactive, they are impulsive. They may have sleep disturbances, bedwetting, night terrors, nightmares. Sometimes it will develop into bullying behavior or violent behavior in school. They may lie, they may steal, emotional problems, they may withdraw, they may become extremely sensitive. The adolescent will become very reactive and they will burst into tears, or they will go into a rage or get very angry. They may have severe mood swings, and they will not remember also sometimes. In a normal child and adolescent, these occur at low levels. We classify it as a disorder when the symptoms are frequent, intense, long lasting, and they cause impairment. They get in the way, they obstruct normal functioning. That is when it is important for a child to get help. Suicidal thoughts, suicidal ideation, saying things like, my life is not worth anything. What is the point of living? See, these are immediate triggers. We must immediately seek help. So this is not in our syllabus directly for this chapter, but it is. You can go through it. It is. These are some of the symptoms of generalized anxiety disorder that you may recognize in children with this condition. Now, on the developmental side, we can see that aggressive behavior can be observed before age 5. Early aggression is linked to high reactivity and poor impulse control. You may see this in school children. In the early school children, some children will be very aggressive and they are not able to control themselves. Coercive and inconsistent parenting. This is an important factor. Parents who are harsh. So if the father is harsh, the mother will try and protect the child. Or if the mother is harsh, the father will try and protect the child. This sends a mixed signal. It causes the child to believe that the parent is not credible, that I cannot trust the parent. These could lead to aggression, when the child themselves sees the behavior modeled. Stressful family environment in which there are absent parents, there is instability or there is conflict. This is it. It is one of the stages of the developmental course. Persistent aggression can cause peer rejection. It can cause affiliation with a deviant group. In schools, many times these children are classified as they are the bad children, and many times they will own it. They will say, yes, we are the bad, we are the gang in school. You will see these behaviors. It is important to see these behaviors, the deviant peer group, recognize and analyze why there is a deviancy. They may have academic problems, unexplained drop in marks, discipline issues in school, and it has a tendency for it to develop into antisocial behavior, substance abuse, etc. Children who do not learn the acceptable ways to express emotions are at risk of developing escalating behaviors. Now, we are looking at disruptive behavior disorders. The disruptive behavior disorders, again, it is important to note they are persistent patterns of behavior. They're not one time. They are frequent violations of the social norms, rules, and rights of other people. So we will look at these three. ADHD is usually grouped with this, but DSM-5 classifies ADHD as neurodevelopmental. That is because ADHD is one of the most studied disorders because of its prevalence. One of the reasons is the prevalence. So just to look at what is the difference between the three. நம்ம டெக்ஸ்ட் புக்ல பேராகிராஃப் எழுதியிருக்காங்க. அதை நான் கொஞ்சம் கண்டென்ஸ் பண்ணி just to understand a gist. So ADHD is considered neurodevelopmental, that is issues with executive function, focus and impulse control. Now, upon developmental, it is looked at as being partially inborn. We look at it as an inborn thing. ODD or oppositional defiant disorder is considered behavioral or emotional. That is, it's associated with an angry mood, defiant behavior, vindictiveness. If somebody does something that the child perceives as bad, the child will remember it and they will want to take revenge. Conduct disorders is more about violating the basic rights of others. So the intent, one is it may be unintentional. I didn't think, it just happened. The difference between that and oppositional defiant disorder is because a parent has said, I will not do it, or I want to trouble you, I want to annoy you. But conduct disorders are malicious. I'm not bothered. Let it hurt anybody, it's okay, let them die. See, many times you will see this in older, you will see it less in children and more in adolescents. Now, ADHD, the relationship to rules is the child will struggle to follow the rules because either they are not focused or they are not remembering. But ODD is an active refusal to comply with rules. Conduct disorder, they deliberately break it at a much higher level. ADHD patients are rarely aggressive. They may be rough, but because they are hyperactive, but they are not aggressive. ODD is aggressive towards specific people, mostly authority figures. They get along with peers fairly well. There are exceptions, but these are the observed tendencies. Conduct disorder, they are physically aggressive towards people, towards pets, towards animals, towards inanimate objects sometimes. They will they take offensive behavior to a next level. An ADHD person may even feel bad. An ADHD patient a child who suffers from ADHD may feel bad. They may admit to the mistake. A child who with ODD will blame others, but a person with a conduct disorder, sometimes with other psychopathologies um, uh, or sociopathy, will not feel guilt, or they will not show guilt. So similarly, destruction, it may be accidental, calculated, or malicious. This is one of the key indicators of how of where a child or an adolescent may be, whether it is accidental, calculated, or malicious. This is a very, very key difference that comes out when you are taking the case history. Now, the target of the behavior, ADHD, because it is not, most of the time it is not intentional, there is no target. It just happens. But ODD occurs with authority figures. Conduct disorders, especially psychopathy and sociopathy, may occur with anyone. Like I said, even with inanimate objects. Now, if we understand these three, it is easy to look and see what the difference between these three are. The details, you will actually find them in the written in paragraph form, but I have taken them and put them into a table where to help us understand. We will not get, for the lack of time, we will not get into all these in complete detail. I'll cover some of these tomorrow as well. But roughly, ODD, the onset is by age 6. They showed irritable behavior, temper outbursts, arguing, blaming others. They are annoyed, they have vindictive behavior, neopdysengia, naivdysayapura. That tit for tat behavior in a much more heightened way. How do you differentiate it from normal defiance? It is very frequent, it is very insistent, and it is atypical. It is not normal for the age in comparison to their peers. So it, to the point where it impairs family functioning, or they are not able to form friends because of the vindictive behavior. These are some of the characteristics of ODD. Now, ODD occurs, now causes and some of the dynamics is, if you see this, the child will misbehave, the parent will respond harshly, the child will escalate, and then one of two things happen. The parent will give in or the parent will escalate. Or in many cases, we will find that one parent will give in, one parent will escalate. So this causes a drastic shift. So even children, because they are vindictive, they will take sides with one parent or the other. So the environment in which we see this is where children are criticized highly. Their negative attention that they receive, the shouting or the beating that they receive, are more than the positive reinforcement. Inconsistent discipline, like I mentioned, one parent will be very disciplinarian, other parent is very permissive. Rules keep changing in the house. So like that, there are other patterns that these and other patterns, these are the dynamics of ODD. Some children with ODD progress to conduct disorders. 75% do not, but 25%, which is a very high number, it goes into internalizing or externalizing behaviors. So this is a case study of a 4-year-old girl whose father was on military duty. So she began to misbehave with the mother. This is the paper I have given in the footnote. It's a existing case study where she would have tantrum, she would not obey the mother, she will shout, and there was a loss of control. So when she came to her to a therapy environment, it was established the attachment disruption was established, and her behavior was partly seen as an attempt to regain control and express the distress because her father was not an absent parent. So what the intervention done was, there was regular psychotherapy to allow for the correct emotional expression to cope, and coping strategies, how to cope with the father's absence. And also structured mother-child playtime. This is a very important aspect. Structured time with a parent, the quality time, not like they say in Hindi, but structured time. Improving that is a regular time, and there is a fixed time where a parent and a child give each other attention, share jokes, share laughter, listen to each other. In Mary's case, it improved the relationship quality measurably. I can share links to the paper. Some of you may have already seen this. Conduct disorder is a repetitive and persistent pattern of behavior. So, as we saw earlier in the table, it infringes on the basic rights of others. There's bullying, cruelty, use of weapons, use of household objects to cause harm. Fire setting. Some children have the tendency, they love fire. They'll want to light things on fire. Deliberately breaking things. These children, many times, they are, unfortunately, in our juvenile justice system, are not given, they are given discipline, but they are not given the accompanying psychological care. Psychological care, because many times they are not diagnosed. And many times they come from low socioeconomic backgrounds, but now an increasing trend is that they are also coming from middle class and upper economic socioeconomic backgrounds. So some of the symptoms you will see is truancy, running away from home, staying out at night late, lying about where they are, what they are doing. And these are some of the symptoms you will see of conduct disorder. I have added some extra information. This is a mixture of extra information and some of the information from the textbook. You will see sexual activity, alcohol and drug abuse, biking for young teenage boys and girls, car drag racing, getting into fights. So these are some of the behaviors we tend to see. Children see others as hostile, even if they are not. Children see, they look at, many times we blame it on TV and video games. It may not always be, those may be contributory factors, but in many cases the disorder has developed even earlier. So they may have a low self-esteem, which has over time led to such a disorder. Now, the long-term consequences, again, we have seen suspension from school, legal problems, delinquency, STDs, sexually transmitted diseases, and things like that. So today, I think we are almost out of time. So we will stop it at this. We will look into the case study and the family and parenting correlates tomorrow. We will, if there are any comments or questions, I know many of us in this session have much experience. So if anybody wants to share your experience or you want to ask a question, please feel free. We have about 3-4 minutes.
Questions, anybody?
All right. So if there are no questions, no other questions, thank you for your precious time. Before we go, please take a look at this is our key slide for today to understand the differences between ADHD, ODD, and conduct disorder. These are the key points for us to be able to understand the differences. Tomorrow, we will look into the case study for conduct disorder, and then we will go into the the most studied of the disorders, attention deficit hyperactivity disorder, before we go into therapy therapy modalities for chapter 7. So, sorry, we go into psychological assessments for children for chapter 7. But, if there are no other questions, thank you everybody for joining and for your participation. We appreciate it very much.
Can you hear me, Alan?
Go ahead, Kat.
Hi. Thank you so much, and everyone. And I want to share one thing. Today, I had a good experience talking to a 10th standard children today. Divya also joined me today and is talking to the 10th standard children there. It was a wonderful experience interacting with them. And today, so as Alan said, I found like few children were not very attentive. They are actually getting distracted easily and all that. So we are going to have a separate session for those difficult children also in the coming week. And so I think whatever you're learning, it should be useful for the next generation. So all the best, and thank you once again, because all these classes is to enhance your knowledge, and then not only an exam based, but it has to enhance your knowledge so that you will be a better psychologist. Thank you. Good night, everyone.
Thank you, ma'am. Good night.
Thank you, sir. Thank you, sir.